thank you to the organizers for inviting me here today. Whilst I did not personally know Earl Wynands, I feel very privileged to give this lecture, and I do want to tell you that the weather here in New Orleans is a lot better than in Toronto. My hypothesis today is that blood transfusion is in fact an expensive and potentially hazardous alternative to patient blood management. And as King Henry VIII said to each of his 6 wives, I won't keep you long, but for the next 45 minutes, I want to talk to you about how we got to where we are in transfusion medicine, why we need blood conservation, how we do it, and talk to you about the Ontario program. Now, patients think that blood transfusion is special and beneficial, but have difficulty accepting small risks they can't control. Blood donors believe that their contribution is a gift to the community that will be used appropriately and safely. Clinicians, on the other hand, believe that blood is ordinary and blood transfusions are taken for granted, benefit is assumed, and risks regarded as minimal. And governments view blood as a commodity and transfusion medicine as an expensive support service which should be regulated and funded in a cost-effective manner. Sorry, this is difficult. This is St. Januarius, or St. Gennaro, who's you can see in the central picture carrying a vial of arterial and venous blood in his arms. And he was the Bishop of Benventum who was beheaded in 305, and cruets of his blood were buried in the cathedral at Naples. And every feast day, his blood is taken out, these vials of blood, and looked at. And they have reportedly liquefied and solidified and liquefied and solidified and liquefied and solidified over 1,800 times. So he became the patron saint of blood transfusion. Now, anesthesiologists also have a patron saint, and I don't know how many of you know this, but Saint René Gopal was a missionary to the Hurons who was killed by the Iroquois for making the sign of the cross on a child's head. And presumably as the tomahawk hit his head, he was rendered unconscious and became the patron saint of anesthesiologists. Unfortunately, he died, and I don't want to push that analogy too far. Now, what's often regarded as the first transfusion is in 1492 when the aging Pope Innocent VIII thought that perhaps he could be rejuvenated by the blood of young boys. We do know that 3 boys were found. They were paid a ducat apiece. It was a paid donor service. And we don't know whether the Pope got the blood as an infusion or as a drink. We do know that the Pope died, the boys died, they were bled out, and the physician fled the country. And there were no more transfusions in Europe for another 150 years. But through the 17th century, there were infusion experiments done, for example, by Christopher Wren or Robert Boyle, and these included intravenous wine, beer, opium, emetics, water, nitric acid, and sulfuric acid. But it was the understanding of the circulation by Harvey in 1613 that really rekindled interest in blood transfusion. And Richard Lauer, the College of Surgeons in Oxford, is credited with performing in 1665 the first authentic blood transfusions, which were animal to animal. And the importance of Lauer is that he was the first to define the appropriateness of transfusional replacement of blood in severe hemorrhage. The first transfusion to a human was Jean Denis, who was a young physician of Louis XIV in Paris, and he said he preferred animal rather than human blood as the donor because he believed it to be less likely to be rendered impure by passion or vice. Now, there was a man who developed syphilitic madness, which was manifested by his running naked through the streets of Paris. And his wife came to Denis and said, well, maybe the blood of a calm animal will quieten him down. So he was transfused, and he calmed down, but he philandered again and was transfused again and died, presumably due to anti-species antibodies. So the man's wife then charged Denis with poisoning her husband. He was exonerated, and the wife was charged with poisoning of her husband. But this incident led to the prohibition of blood transfusion in France, in Britain, by the Vatican, and again there was a near 150-year hiatus in transfusion work. Through the 18th century, transfusions were done only sporadically, generally animal to human. They were thought of as a cure for a mental aberration or as a youth potion for the aged. Reciprocal transfusions between husband and wife were suggested as a cure for marital discord. Blood was thought to carry the characteristics of the donor to the recipient, so that sheep's blood would make a dog grow wool, hooves, and horns, and so on. But in 1818, James Blundell, an obstetrician at Guy's Hospital in London, is the first to, on a regular basis, transfuse humans with human blood. And he said he preferred human donors because what would you do in an emergency? A dog can come when you whistle, but it's small, you can't get much blood. And a cow might be better, but it hasn't been taught to walk properly up the stairs. So he preferred human donors. And between 1825 and 1830, he did about 10 transfusions, of which 5 were beneficial. And he said that the fact that life may be saved by transfusion of blood into the veins will be beneficial 1,000 years hence as it is on this day. And blood indeed could be good stuff, as this article from 1825 tells us, that following transfusion of a woman with her husband's blood, the woman, previously semi-comatose, suddenly exclaimed, "I feel as strong as a bull." But in 1849, Routh reviewed all reported cases of transfusion to that date, of which there were 48, and 18 had a fatal outcome, which he estimated was a mortality rate rather less than that of a hernia operation and about the same as an average amputation. Transfusions through the 1800s were plagued by complications, but it was gradually recognized that same-species transfusions were more effective than interspecies transfusions, but animal-to-human transfusions were performed as late as 1890. But gradually it was recognized that human blood only should be employed, and that when lamb's blood is used, an invariable result seems to be the escape through the kidneys of hemoglobin. Now, one of the problems, of course, is when you took blood from a donor, it tended to clot. So transfusions were generally done by artery-to-vein cannulation or using paraffin-coated tubes. Saline was first used as a blood substitute in 1884 and was found to be safer than and frequently as effective as transfusions. And milk was advocated as a potentially effective infusion because it was thought that the white corpuscles of milk would be transformed into red blood corpuscles. And the Canadians, as always, were in the forefront of medical research. And in 1854, in Toronto, during the cholera epidemic, intravenous milk was infused, and they described how in a few seconds the pulse was distinctly felt. The eyes and the lungs responded to the vital tide which now flowed toward them, and the voice, which was unearthly before, was clear. Now, it wasn't always easy to be a blood donor, and this is some equipment from the 1870s of how capillary blood was obtained, and you can see the plunger with the nails at the end is pushed into the donor's back. Capillary blood is collected into the syringe, and it is administered to the patient. So, tough. But transfusion entered the scientific age in 1900 when Karl Landsteiner described the ABO blood groups. And this description was, in fact, a footnote in an article on bacterial fermentation. Nonetheless, he won the Nobel Prize for this in 1930, and while he recognized the importance, the clinical importance of his findings, it took 7 years before his students were the first to apply this in an actual transfusion. But experiences in the First World War led to the universal adoption of blood typing to select donors. During the First World War, sodium citrate was discovered as an anticoagulant in 3 centers, And Dr. Lilienthal, who performed the first transfusion on a human using this citrate method, wrote that the ease and simplicity of this transfusion was most amazing to me, who had often suffered so much more than the patient in performing this life-saving operation. And in the Second World War, Mollison described the use of acid citrate dextrose, and which allowed blood to be kept instead of 7 days, now to be kept for 21 days, and various modifications of acid citrate dextrose as anticoagulant preservative solution have allowed us to now store blood for up to 42 days, or maybe even longer. In 1939, if you wanted blood, you could only get whole blood and plasma. And I think blood component therapy is one of the great advances of the last 60, 70 years. Blood used to be collected into reusable glass bottles, and pyrogenic reactions from contamination due to incomplete cleaning were frequent. Air embolism was a common complication because of the vacuum system used in the glass bottles. But in 1949, the American naval surgeon, Walter, conducted trials of plastic bags, and these were disposable, and because of their flexibility, allowed for safe separation of blood into components. Other major advances through the 20th century were the reintroduction by Coombs, Morant and Race in 1945 of the Coombs test, allowed us to be able to detect immune or IgG antibodies and discover new blood group systems, development of blood banks, therapeutic products like platelets, cryoprecipitate, arginine globulin made big differences in terms of patient welfare, and there's been a lot of advance in infectious disease testing and prevention of transfusion-transmitted infections. What will the 21st century bring? Well, I think we're already seeing a paradigm shift from blood transfusion to blood conservation or patient blood management. There will continue to be effort in error and adverse event preventions. We may have problems of supply and demand. There will be new techniques used in blood transfusion, new products, and hopefully we'll begin to better understand the immunopathophysiciology associated with transfusion. So when it comes to red cell transfusion, what do we know? Well, in fact, evidence of benefit from red cell transfusion is hard to find. There's never, ever been a prospective randomized trial that established the life-saving benefit of red cell transfusions. And we assume the benefit, although it isn't proven. It's obvious, it's clear that some patients will benefit, but we need to be able to better identify which patients they are. We have learned that giving more blood is not necessarily better, and the literature indicates that many transfusions, as many as 50 or 60%, are probably unnecessary and inappropriate. So as everything in medicine, we need to look at risk versus benefit, and known risks should outweigh perceived benefits every time. So what is it that people are afraid of? Well, what patients are afraid of are viral transfusion-transmitted infections. And these are the data in Canada of residual risk of a screened unit of blood. Risk of HIV, 1 in 10 million, Hep C, 1 in 5 million, Hep B, 1 in 1.5 million. Now, it's very hard for people, patients, even doctors, to understand what these kind of odds mean, because I know that if anybody understood these kind of odds, nobody would ever buy a lottery ticket. So to put it into some kind of perspective, these are the risks of death from Canadian actuarial tables. The risk in Canada of dying in a motor vehicle accident, 1 in 9,000. Being murdered in Canada, 1 in 85,000. Being murdered in Toronto, 1 in 800. The risk of being killed by lightning, 1 in 3 million. Now, nobody's afraid to go out in a storm. Nobody's afraid to get in a car. But everybody is terrified about getting HIV or Hep B or Hep C from transfusion. There are other issues why we don't want to give blood, in addition to viral and bacterial transmission. You're familiar, of course, with the allergic, hemolytic, TRALI, TACO, errors associated with transfusion administration. And over the last 25 years, transfusionists have become increasingly interested and concerned about transfusion-related immunosuppression or immunomodulation. And if, as it has been clearly shown transfusion induces immunosuppression, one would expect to see a higher incidence of infections in patients who are transfused. And 10 years ago, Hill reviewed 23 peer-reviewed publications to that date and showed that the odds ratio for bacterial infections in patients who were transfused versus those who were not transfused was 3.5. And a large prospective study more recently identified red cell transfusion as the strongest independent predictor of all-cause morbidity and mortality after isolated cabbage. And we know then that transfusion is correlated with increased time to extubation, length of stay, morbidity, mortality, and the risks increase with the more units used. And this is true also in cardiac surgery, as you can see from these two meta-analyses looking at the effect of red cell transfusion on postoperative infection and on mortality. And you can see that in every single study, the results favor the control or no transfusion versus transfusion. Now, in the United Kingdom, hospitals voluntarily report all adverse reactions associated with transfusion to a central body called Serious Hazards of Transfusion, or SHOT. There are some that lament the fact it wasn't called Serious Hazards in Transfusion, but it wasn't. And I draw your attention to the large red area, IBCT 80%. And IBCT stands for Incorrect Blood Component Transfused. And an incorrect blood component transfused is, without exception, an avoidable error. Where do these errors occur? Well, 4% occur in the blood center, 28% occur in the hospital blood banks, and 68% occur on the wards, the nursing units, the OR, and I think there's a really important message there. Now, in Canada, blood is so-called free. No hospital, no patient pays for blood. It's paid for by the central federal government or provincial governments. But of course, there is a cost to blood. There are direct and indirect costs, product, tubing, supplies, labor, transport. And in Ontario, the cost of producing a red cell unit has been estimated to be around $450 a unit. And this translates into really quite considerable budget, so that the Ontario blood budget for red cells alone is around $250 million a year for a population of 13 million. But there are additional costs. There's hospital blood bank, nursing administration, monitoring the patient, clerical costs, and further resource use in the increased length of stay and treatment of complications. And a large multi-center observational study showed that transfusion can increase hospital costs by 40% and estimated the cost of a transfusion at $1,200 to $1,400 a unit. Also, we may run into issues of supply and demand, as we have periodically from time to time. We know that as boomers age, the potential demand grows exponentially. The average use for patients under 40 years of age is 5 units per 1,000 population. If you're greater than 70 years old, it's 200 units per 1,000 population. So there are concerns, and it is clear then that the demands for blood may outweigh the supply, the real risks associated with transfusion, and that blood is in fact not free. So why do we give blood? Well, a study looking at 5,000 patients in 284 ICUs by Shander and Goodnow, both of whom I see are speaking later at this meeting, I noted that in 95% of cases, or over 90% of cases, the documented reason for the transfusion was a low hemoglobin. So patients are being transfused for laboratory-diagnosed anemia and not for symptoms. And one of the easiest and least expensive ways of transfusing less blood is by dropping the transfusion trigger. The problem is that anemia is often accepted as a normal part of doing business. We know from abundant literature that 30 to 70% of patients come to surgery anemic, but there's a long tradition of accepting anemia as relatively harmless, and you can correct it easily with transfusion. But anemia is an independent risk of morbidity and mortality, and it increases the cost of delivering healthcare by more than 50%. How do we treat preoperative anemia? Well, with iron, either oral or intravenous, and we can use erythropoietin. Now, there have been concerns about increased incidence of VTE with erythropoietin, and I draw to your attention two facts. One is that the studies on which the black box warnings were predicated were done based on 4 studies, 3 of which were in patients with malignancy, who we know are more hypercoagulable. Secondly, the hemoglobin levels in those studies were pushed really very high. And the 4th study was the spine study in spine surgery, in which patients, as part of the protocol, were not put on anticoagulants post-op. So I think that one needs to look at that, but examine it carefully. And this recent expert opinion review says that the use of erythropoietin to surgical patients has few adverse effects because it is a short-term treatment and we don't give it to patients with comorbidities that may predispose to VTE, like arterial hypertension, previous acute MI, so on. So I think that many people in the transfusion field and elsewhere do believe that it is safe to give erythropoietin in the preoperative setting. We don't want to push the hemoglobin too high, so people have made a cutoff of a target hemoglobin of 120 or 130, but 12 or 13 grams per deciliter. But establishing a definitive hemoglobin transfusion threshold has in fact proven difficult, although studies have shown that mortality increases in patients with a hemoglobin below 5 grams per deciliter. For healthy individuals, it might be lower. The threshold might be lower, but comorbid conditions may influence this threshold. Probably the best study looking at restricting the transfusion to a lower hemoglobin is the TRIC study, which is now 15 years old, and in which patients in the ICU were given transfusion when the hemoglobin fell to 10, or only given transfusion when the hemoglobin fell to 7, the restrictive arm. And in the restrictive arm, of course, patients got less blood, they had lower hemoglobins, but when one looks at morbidity, mortality, and organ failure, there was no difference between the two groups. In 2012, there was a Cochrane analysis of the literature on restrictive versus liberal transfusion therapy, and the summary of this Cochrane analysis says that a restrictive transfusion trigger reduces the risk of exposure to red cell transfusion and the total number of units transfused, and the published evidence suggests that the restrictive transfusion triggers do not adversely affect mortality, cardiac morbidity, function, or length of hospital stay, and they recommend the use of a restrictive transfusion trigger, although they do advise caution in patients with high-risk groups such as acute coronary syndrome. So while several studies do indicate a general lack of compliance with appropriate and accepted transfusion guidelines, as well as tremendous variation in transfusion practice, and in terms of variability in transfusion practice, there was a recent review by Bennett Guerrero of 80,000 CABG cases in 400 hospitals, in which the institutional transfusion rate ranged from 8% to 99%, which I think is quite remarkable. But nonetheless, many individual physicians, many institutions, many individual physicians are steering towards a hemoglobin trigger of 7 for transfusion, regardless of comorbidities. Many will use 7 for healthy patients and 8 for patients with cardiorespiratory problems. But I think the main point is to avoid transfusing healthy patients, non-bleeding, stable patients, based on hemoglobin alone. Now, there are very few studies of transfusion trigger in cardiac surgery, and the 3 studies that there are fairly small numbers of patients. And I draw your attention to the TRIX-3 study, which will be a global multicentric trial of transfusion triggers in cardiac surgery that is just beginning, and I think is looking for institutions to participate. And if you're interested, my colleague on the left is the person to see. Now, I think in the end, the decision to transfuse may be too complex and too important to be guided by a single number, and that transfusion decisions need to be based on individual patient characteristics, age, cardiovascular disease, and so on. And to remember that we don't deal with the average patient, but rather with the individual. And patients want to know not only what their options are, but also what is right for me. We need to work with them to make informed decisions. Now, we know that cardiac patients in particular may be at increased risk of anemia, hemodilution, and transfusion. But with the optimal transfusion threshold, we're still in this population is uncertain and controversial. So we need to use clinical judgment and perhaps physiological variables such as tachycardia, hypotension, so on, may be useful. But to date, I think the quality prospective data remain lacking. And we recognize that clinical parameters may not be too helpful in patients under anesthesia. So why do we give red cells? Well, we give it, of course, to restore tissue oxygen delivery. But red cell transfusions may not always improve oxygenation. For example, increased viscosity may reduce microcirculatory flow. In sepsis, altered oxygen extraction capabilities and red cell deformability may reduce the amount of oxygen downloaded to tissues. And we have few tools to determine the adequacy of tissue oxygenation, which can assess the likely patient benefit in individual patients. I think that we have some tests that we use, cardiac output, venous oxygenation, lactate levels, give some sense of global oxygenation, but not of regional tissue oxygenation. And while there are techniques, newer techniques to monitor the microcirculation, these remain still, I think, experimental. So why do we need to change transfusion practice? Well, blood transfusions occur in the United States in 1 in 10 of all hospital stays that had a procedure. And it is one of the fastest growing top 5 procedures in hospitalized patients. Transfusion, however, does increase morbidity, as we've shown, and mortality. And these 2 studies show you that mortality or survival rate survival rate decreases, mortality increases with transfusion, and particularly the more transfusion you give, the greater the likelihood of death. And it's been shown that up to 60% of transfusions are unnecessary or inappropriate given to stable, non-bleeding patients. Now, in 1997, the Crever Commission, and the Crever Commission was the largest federal commission and longest-lasting federal commission in Canada into the tainted blood scandal, stated that blood components and blood products will never be without risk. And the best way to reduce that risk is to reduce their use. And despite important advances to reduce transfusion risks, this statement remains true today. Which brings us to patient blood management, or PBM. And the aim here is to avoid allogeneic transfusion, and when you do have to transfuse, give as little as possible. And the cornerstones of patient blood management are to correct preoperative anemia, to minimize perioperative blood loss, and to use minimal hemoglobin-based transfusion triggers. Now, there are many ways to achieve these aims. Hemoglobin enhancement, autologous blood, probably the most useful and maybe only useful one is cell salvage, prevention of bleeding, surgical technique is the most important factor in all this. And I draw your attention to the really superb STS-SCA guidelines for blood conservation and transfusion in cardiac surgery cases that were updated in 2011. And they really are excellent articles, and everybody should read them. This slide shows you some of the benefits of the techniques in recent literature. The panel on the left is intraoperative cell salvage in cardiac surgery, and you can see that when cell saver is used, there is a significant reduction in red cell use, not much difference in plasma use. The panel on the right is looking at thromboelastography and elastometry in cardiac surgery, and you can see that when these techniques are used, there is a reduction in utilization of red cells, plasma, and platelets. So in 2002, I went to the Ontario Ministry of Health and suggested that they fund a network of Ontario transfusion coordinators. While there are many hospitals in the United States, there were relatively few in Canada that had blood conservation programs at the time. This program was unique in being a network of many hospitals under one umbrella. And the ministry funded this, and the aim of these coordinators is to enhance transfusion practice outside of the blood bank, to interact with physicians, nurses, and patients to promote blood conservation and alternatives to allogeneic transfusion. And we told the ministry that we anticipate a 5 to 10% reduction in red cell use. So 25 hospitals were chosen based on blood utilization and geography, and these hospitals accounted for about 70% of the blood used in the province, around 400,000 units of red cells annually, for a population of 13 million. And what we initially focused on knee elective CABG, aortic aneurysm, surgeries, and we've now added hips and radical prostatectomies, and more recently, valves. At specific time periods, the coordinators collect detailed anonymized patient information for a defined number of all consecutive patients, whether they've seen them or not, so that we get a snapshot of transfusion practice at the time. And the aggregate data sent to the Ministry of Health, and each institution gets its own site-specific data as well. So what do these coordinators do? Well, they try to assess the patient at pre-admission clinic 3 to 5 weeks prior to surgery, identify patients at risk of transfusion, discuss informed consent and transfusion alternatives, investigate, diagnose, and treat anemia with the help of the family doctor, surgeon, anesthetist, or hematologist, and facilitate the use of erythropoietin or iron as appropriate. We don't use much preoperative autologous donation anymore, but they can arrange or advocate for cell salvage and so on, and to minimize blood taken for lab testing. So these are some of the results that we've obtained in our program. The provincial average for percent of patients receiving allogeneic blood or transfusion rate in knee surgery has dropped over the decade from 25% to 3%. In CABG surgery, the provincial transfusion rate has dropped from 60% to 21%. The blue box on the right shows you that not only are fewer patients being transfused, but those who are transfused are receiving less blood. So that, you might remember, we'd hoped for a 5 to 10% reduction. We've in fact achieved a 65 to 88% reduction in transfusion rates in the designated procedures. When one looks at the baseline data of the individual hospitals in this program, you can see the not unexpected but interinstitutional variability. But what was unexpected, to me at least, was the extent of this individual variability. For example, if we look at the knee surgery on the right-hand side, Hospital E had a transfusion rate of 3%, Hospital W a transfusion rate of 68%, and this is for single knee surgery, really where patients should be fundamentally the same patients in every institution. So this was disturbing, but you can see that same was true to an extent in the CABG surgery at the different sites. But in all sites, we've had a reduction and a flattening of the interinstitutional variability. And interestingly, we find no difference between community and teaching hospitals in transfusion rates. Does the type of surgery matter? Well, overall in 2012, the CABG transfusion rate was 26%. The number of vessels implanted didn't make a lot of difference, but revisions or redos doubled the transfusion rate. Minimally invasive cardiac surgery markedly reduces the transfusion rate, and when one does CABG and valves together, this doubles the transfusion rate. Now, one of the things I think, at least from the transfusion side of things, we know about it, but we tend not to think about it, and that is the gender difference. We all know that women have lower hemoglobins, and you can see that in the top table, and that's true at all phases of the perioperative period. But this translates into significantly higher transfusion rates in women, and I think we need to pay more attention to this gender difference, and similarly to patient age, because particularly patients over the age of 70 have a much higher transfusion rate. So we try to raise the preoperative hemoglobin level, and we aim for a target of 13 grams per deciliter preoperatively. And that's based on data that you see here from our program, where if we look at any of the diagnoses for hemoglobin less than 13 grams preoperatively, there is a markedly higher transfusion rate than when the hemoglobin is above 13. And the graph on the bottom shows you the rapidity with which the transfusion rate increases for hemoglobins less than 13. And a preoperative hemoglobin of 10 has a 7-fold higher likelihood of transfusion than a hemoglobin of 13. So we aim for that if we can achieve it. But to treat the preoperative anemia, you need time. And this table shows you the effects of having sufficient lead time to treat the preoperative anemia. And if I look at the knee surgery in particular, as an example, you can see that less than 7 days lead time, 5%, greater than 21 days, half as many patients are transfused. The problem we have in our province is the emphasis on short lead times in CABG surgery, so that only 27% of patients had a lead time greater than 14 days, in contrast to orthopedic patients where more than 60 patients have sufficient lead time. The individual blood conservation measures generally individually will reduce transfusion rates by about 30%. But the key really is to use multimodal blood conservation therapy, many methods simultaneously or in the same patient. So that again, if we look here, and again I'll use knee as an example, if no blood conservation was used, the transfusion rate was 16%, one measure 11%, more than 3 measures, 3% of patients were transfused. So multimodal therapy is really what we would like to use. We look at clinical effects of transfusion, and I think you can see quite clearly that in patients who are transfused have longer lengths of stay and higher infection rates, and the bar graphs on the right show you that this is dose-dependent. The more units of blood given, the longer the length of stay, the higher the infection rate. In Ontario, then, the nadir or transfusion trigger in cardiac surgery is around 7.4 with fairly wide standard deviation, but overall I think we're quite happy with that. One of the issues that has come up is that in 2012 there was a paper in Transfusion looking at discharge hemoglobin as a surrogate marker for red cell utilization appropriateness. And the paper says a hemoglobin level at discharge greater than 10 or even 9 in a transfused patient serves as a surrogate for excessive transfusion. So we looked at our on-track data, and you can see that really 1 in 5 patients, transfused patients, is being sent home with a hemoglobin greater than 10, and 1 in 10 patients with a hemoglobin greater than 11. Now, does this mean we're over-transfusing patients? I don't know, but it certainly raises a flag that we need to think about. Since this program is funded by the Ministry of Health, we have to report to them, and like most government agencies, all they're really interested in is not so much patient care or patient benefit, they're interested in dollars. So we have to give them a cost analysis. And we know from the literature that patient blood management does reduce costs in cardiac surgery. And when we do the cost analysis for our program, for the 4 targeted procedures, knee, hip, prostates, and CABG, the savings to the province annually, the annual savings is around $15 million, and the savings to the healthcare system overall is around $47 million. If we just looked at the CABG patients, there'd be about 90,000, I think, in Ontario annually, and this would represent a saving of $23 million a year. The cost of the program is $3 million. So in addition to catering to many patients' preferences, improving quality of care and patient safety, the program is cost-effective and cost-efficient. So how does Ontario do compared to the rest of Canada? Well, Ontario is in the red line, and you can see that prior to 2002, it was using more red cells per 1,000 population than the rest of Canada and increasing at an incrementally higher rate. And that is flattened out, and we're quite pleased with that. How does Canada do compared to other countries? Well, this is data from 2007, and I know that it has changed and that a number of countries have come down in their use of red cells per 1,000 population. But Canada looks good, but I think in the United States, I think you should look at these numbers, and while it has come down, I think that you should think about your transfusion practices. Now, if the pathways supporting blood conservation are simple in design, labor costs are low, capital investments small, quality and outcome gains high, savings large, and the greater public good is served, one has to ask, why has blood conservation adoption been so slow? And I think it's physician training and traditional practices that told us that transfusion is the default position for anemia and for bleeding. And we transfusionists have encouraged the belief that blood is now safe, and I think that is a mistaken concept. And we need to replace the traditional concept that blood products are an effective therapeutic intervention with the concept that transfusion of blood products is an undesirable outcome. What have we learned? Well, we've learned that transfusion rates are not dependent on patients so much, but are institution dependent, and that there are high transfusion hospitals and low transfusion hospitals. And while we like to blame the surgeon, 30% of the variation has been shown to be surgeon dependent, and 70% of the variation is hospital specific dependent. Now, doing patient blood management or blood conservation is not easy. And this editorial from a decade ago tells us that it requires coordination of services across a variety of departments, cooperation between outpatient scheduling, surgical and anesthesia physicians, their clinic personnel, operating room, intensivists, hematologists, the billing office. And all of this is in contrast to a transfusion, which can be accomplished with a single phone call. Nonetheless, there are many new techniques and therapies available, even though their relative merits, alone or in combination, still need to be investigated. It is becoming standard of practice. The trouble is, when you take this concept to the Office of Director of Medical Services, the response you often get is, I need you to find a radically innovative new way to keep everything exactly the same. Some of the difficulties and pitfalls that we encounter is the emphasis on shorter wait times for surgery often doesn't allow us time to correct the preoperative anemia, which I think is a key feature of a patient blood management program. The changing scientific evidence, for example, with erythropoietin, protein, so on. In Canada, the fact that blood is free to hospitals and patients has been, in some measure, a barrier to change. The cost and accessibility of some of the blood conservation measures. We find that when a coordinator or a physician or an administrator involved in the program leaves, there's a reversal of gains, and it's sometimes quite difficult to recruit physician and administrative champions. So while the Bible tells us that the life or the soul of the flesh is in the blood, we encounter the paradox of transfusion, where blood is critical and can help, but it can also really hurt. And while a number of years ago I might have said the best transfusion is the transfusion not given, I think what we have to say is that the best transfusion is the appropriate transfusion. And I leave you with the famous statement of Dr. Beale from Australia that blood transfusion is a lot like marriage. It should not be entered into lightly, unadvisedly, or wantonly, or more often than is absolutely necessary. And patient blood management is one of the few areas of medicine where you can improve outcomes, reduce risks, save costs all at the same time. And I draw your attention to the website of the Society for the Advancement of Blood Management, SABM, where there is a wealth of information on patient blood management that I think can be a very useful website for you. Thank you very much.